Hi, my name is Saad Usmani. I'm the Chief of Plasma Cell Disorders Division at the Levine Cancer Institute, and I'm here at the ASH annual meeting in Orlando, Florida. I'm going to present the Candor phase 3 trial as a late-breaking abstract at this meeting, and I would like to share some results with you. Candor is a phase 3 trial that is looking at 1 to 3 prior lines of treatment relapsed myeloma, comparing the combination of Carfilzomib, Daratumumab, Dexamethasone with Carfilzomib, Dexamethasone. The randomization schema was a 2-to-1 randomization, which essentially means that for every patient receiving Carfilzomib, Dexamethasone, 2 were randomized to receive the 3-drug program. The trial accrued a total of 466 patients. This study had a median age of about 64 on the Dara-KD and 65 on the KD arms of the study, median of 2 prior lines of treatment, and the treatment was continued on both the arms until relapse, progression, or intolerance to therapy. Primary endpoint was progression-free survival, and it was reached after a 17-month follow-up. The 2-drug arm had a PFS benefit of 15.8 months, and the benefit median PFS on the KD Dara arm has not been reached, with a hazard ratio of 0.63. Overall response rate was 84% versus 73%. The MRD negative CR rates at 12 months were also almost 10 times higher, 12.5 versus 1.3%. From a overall survival standpoint, at the 17-month follow-up period, I think, again, this is short, there were no differences in the overall survival or the total number of survival events. Safety profile-wise, adverse events that were grade 3 or higher were higher in the 3-drug arm and were primarily driven by an increased risk of infections. The cardiovascular risks, however, were a little lower in the 3-drug combination. Specifically, grade 3 or higher cardiac failures were about 4% versus 8.5% in the KD arm. So, we don't know how to explain this cardioprotective mechanism, but we are going to be looking over in more detail to the clinical characteristics. And the other important thing is the fatal treatment emergent adverse events, 5 on the 3-drug arm versus 0. 4 of those events were infection related. So again, from a clinical standpoint, highlighting the fact that we need to pay attention to patients, from the infection standpoint, and there are plethora of abstracts being presented at ASH that talk about that immunocompromise and risk for infections and perhaps prophylactic antibiotics. So it kind of plays into that theme. So why are these data important? We have we have a total of 6 clinical studies that have read out in this setting, and 4 of those studies contain lenalidomide as part of the triplet therapy. But in the US specifically, the practice is using lenalidomide as maintenance continuously. So when patients are relapsing on lenalidomide or becoming refractory to it, we don't have as many options as the len-sensitive patients. So in subgroup analysis, the benefit of Dara-KD was seen in both len-exposed and len-refractory patients. So from a clinician standpoint, I think having an IMiD-free regimen like this is important, and Dara-KD would be a good option for those kind of patients.